The following podcast is part of a certified educational activity titled Disease and Disability Progression in Relapsing MS, Unpacking Efficacy Data to Advance Treatment Decisions. Access the entire activity and complete the post-test at peerview.com/TPK860. Downloadable slides and practice aids are also available.
Very nice to see so many of you so bright and early just before the start of our ACTRIMS Forum 2026. Today, we'll be talking about disease and disability progression in relapsing MS, unpacking efficacy data to advance treatment decisions. My name is Jiwon Oh, and I'm a neurologist and MS specialist at St. Michael's Hospital at the University of Toronto. And I'm very pleased to introduce my co-chair of this program, whom everybody knows, Dr. Bob Fox from the Cleveland Clinic. Okay, so the objectives of the next 55 minutes or so are to discuss a number of topics of relevance in MS clinical care. First, we'll talk about how early intervention with disease-modifying treatments reduce relapse rates and disability accrual in MS. Then we'll shift gears and talk about novel disease-modifying treatments, including BTK inhibitors, as well as other treatments that are bringing new strategies to address relapse rates, as well as progression independent of relapse activity. And then we'll touch on how MS care teams should prepare to leverage evidence to guide therapeutic sequencing approaches to individualized plans as treatment targets shift. And we will be ending with two case studies that Bob and I will present. We very much welcome your input using the app through the Q&A. And then we do have a dedicated session of 10 minutes at the end so that we can specifically address questions that you might have. Okay, so I will start off by talking about how we should be reframing progression in the context of relapsing MS. And then we'll talk a little bit about the rationale for early high-efficacy treatment, as well as unmet needs that we currently have when we're talking about treating relapsing MS. So I know that many of you over the years have seen this diagram probably frequently at different congresses, and know very well that in the last number of years, there's been a shift in terms of how we look at MS. In the past, anytime you open an MS textbook, there's a very neat kind of subtyping and categorization of MS into specific subtypes. So there's always relapsing remitting MS and secondary progressive MS, and then you have primary progressive MS. And we thought that in general, most people with relapsing MS, their pathophysiology is largely driven by peripherally mediated inflammation. So these are waves of inflammatory cells that get into the blood-brain barrier and get into the brain and spinal cord and cause focal acute lesions. And we thought this was the prominent driver of relapsing disease activity well into the disease course until at a certain point, chronic compartmentalized processes, which are depicted here, including the development of chronic active lesions, meningeal inflammation, and cortical pathology start to contribute more heavily to pathophysiology. And this is the point when we thought that MS transitioned into secondary progressive MS. But what's becoming clear is that there's not this magical time point when this transition happens clinically or pathophysiologically, and it's becoming clear that the disease subtypes that we currently use probably need recharacterization based on a lot of evidence that's accumulated, and we'll talk about that in a second. And this big, dark kind of delineation that you have between relapsing disease biology and progressive disease biology, in fact, does not exist. And probably all of these pathophysiologies play a role throughout the entire course of MS, even at the very earliest stages of disease when people are presenting for the first time with relapsing MS. So it's clear that Inflammation plays an important role throughout the disease course, whether it's peripherally mediated inflammation or chronic compartmentalized inflammation. This takes place in different compartments throughout the MS spectrum and disease course. But what we're recognizing again is that MS is a disease spectrum, and all of these pathophysiologies likely play a role in most people with MS throughout the entire disease course, although it's true that probably in later stages of MS, some of these chronic compartmentalized processes play a more dominant role. So it's clear that MS historically has been seen as a disease that starts and is predominantly driven in the relapsing stages by peripherally mediated inflammation. And then you get into the central compartmentalized stage. But again, we're recognizing that all of this is taking place probably from the very beginning of the disease. And one of the clinical studies that I think probably illustrated this very clearly was the first systematic description of PIRA, or progression that is independent of relapsing activity. And this was a post-hoc analysis of the pivotal phase 3 trials that looked at the effect of ocrelizumab versus interferon beta-1a in people with early relapsing MS. So this was a typical contemporary clinical trial that recruited people with relapsing MS. The average disease duration prior to trial recruitment was approximately 3 years. So these are people that are pretty early in their disease course. And what was surprising was that when you look at this concept of PIRA, which again is progression that is happening outside of the window of any clinical relapse, what was surprising was that all of the disability progression events that were seen in the clinical trial, the vast majority of them were PIRA, as you can see from these two figures here. And this was regardless of whether you were treated with ocrelizumab or interferon beta-1a. It's clear that when you compare the two figures, that people treated with ocrelizumab had a lower proportion of people that developed PIRA. Nonetheless, it was surprising that even with ocrelizumab, an anti-CD20 agent that is still one of our highest efficacy agents, it's very clear that disability still does occur. And when it does, the vast majority of events are driven by PIRA. So this is that chronic compartmentalized processes that we were talking about. So what we're now recognizing again is that, and I think this diagram depicts it pretty well, it's not just relapses and relapse-associated worsening that is responsible for disability progression in relapsing MS or early in the disease course. There's also concurrently PIRA that is happening, as you can see from this diagram here. And over time, PIRA probably plays a more dominant role in mediating disability as people get further along in their disease course. So what does PIRA mean clinically? Well, since that first kind of systematic description, based on those trials that I just showed you, a number of groups have looked at whether having early PIRA events has any predictive value in terms of how disability accumulates. And the Barcelona group looked at their very nicely characterized cohort of people with clinically isolated syndrome. So these are people presenting with the first clinical symptom of MS. And as you can see, in people who have early PIRA events, the likelihood of developing disability in the ensuing 2 decades is much higher, as you can see from these survival curves here. So if anybody has an event of PIRA after a first demyelinating event, their likelihood of developing significant disability is increased substantially within the first 10 to 15 years after disease onset. And so I think we're recognizing that despite the fact that we have nearly 30 different treatments, that many of them are really, really good at reducing or getting rid of relapses altogether, reducing or getting rid of any new MRI disease activity altogether, that there is still clearly an unmet need in clinical practice. And this is what Dr. Fox will be talking to us about in a second. However, when we think about how we currently approach treatment in relapsing MS, way back in the day when treatments first emerged, there was this debate about whether we should start treatment early or not. And it became very clear as evidence accumulated how important it is to start treatment in people with MS. And then since we've had access and wide access in recent years to many high efficacy treatments, this question of whether we should start with high efficacy treatment has been a debate. And I think based on accumulating evidence from thousands of patients around the world, it's pretty clear that in most people with MS, early high efficacy therapy should be considered because there are many benefits of early initiation of high efficacy treatment, including reducing long-term disability, obviously earlier on reducing relapses and delaying conversion to SPMS. However, we also know that most people with MS present in their late 20s and early 30s, and there certainly is a risk associated with longer-term immunosuppression. So some of the challenges that we have in MS clinical care is balancing the need for early high-efficacy therapy and the fact that these are chronic therapies that over time do have some risks in some people. So some of the evidence supporting the use of early high-efficacy therapy, this was a very nice study done a number of years ago looking at large registries that very clearly show that when people are started on high-efficacy therapy within the first 2 years of MS onset, there very clearly is a benefit with respect to disability progression over 8 years, as you can see from these survival curves here. I think, based on the study that I just showed you, as well as many other large registry studies around the world, there's no denying that very clearly there is a benefit in the short as well as longer term of starting high efficacy treatment at the very beginning of relapsing MS. However, at the same time, as we discussed, over time, and MS is a disease that lasts for decades, if not a lifetime, there is this question of what happens if you continually immunosuppress people for decades at a time. And this is precisely why, because most of our MS patients will become older at some point, there is this question of when treatment can be safely discontinued and a number of discontinuation trials that have emerged. And I think the jury is still out because it is clear that based on the DISCOMS trial that was done, in most people who have been stable for many years over the age of 55, you can discontinue treatment, but there is a small proportion of people that will have disease activity. And then in some recent studies, including the DOT-MS trial that looked at discontinuing therapy in people, in all adults with MS, but the mean age in this trial was actually just under 50. As you can see, this trial was actually stopped in the middle because very clearly in many people, I shouldn't say many people, in a significant proportion of people, there can be disease activity after treatment discontinuation, even when people are in their 50s on average. And then the French offset registry trial looked at the discontinuation of high efficacy treatments, including natalizumab, fingolimod, as well as anti-CD20 agents in people 50 and above. And as you can see from these survival curves here, in all people, there was a significant risk of discontinuing higher efficacy treatment with evidence of relapses as well as MRI disease activity. But when you actually break it down by different therapy, and I know the text is a little bit small, but as you can see, this is for natalizumab, this is fingolimod, and this is anti-CD20 agents. With natalizumab and fingolimod, there was a significant risk of disease activity return. However, with anti-CD20 agents, there was not a significant risk. So the data are still evolving. It's very clear that in many people with MS, at some point we will consider discontinuing therapy, but we're not quite sure yet how to do this safely, and this is why we need additional information from around the world. Just a slide outlining some of the risks that we know that can occur with long-term therapy, particularly with anti-CD20 agents like ocrelizumab. And this was an abstract that was presented very recently at ECTRIMS. But it is very clear, and we know this over time, these are extremely well-tolerated, highly efficacious therapies. But overall, long-term exposure is associated with a higher risk of serious infections, as well as a shorter time to first serious infection. But what was interesting was that in this study, despite the fact that one of the hypotheses was that serious infections would be seen more commonly in older people over the age of 60, this was actually not a relationship that was seen in this abstract. Nonetheless, it is very clear, again, based on this study, which included nearly 4,000 participants, as well as other studies emerging around the world, that there is a risk with long-term high-efficacy therapy, and it's clear that we need better guidance as to what to do do after people have been on therapy for a very long time. So we've covered a lot of points. We talked about how PIRA is the dominant driver of disability, even in this era of high efficacy therapy for relapsing MS. And so clearly there are unmet needs. We know that current therapies, although some of them do address a small component of PIRA, they do not completely address this issue, and this highlights the need for novel treatments. And so very clearly, we also need guidance about what to do as people with relapsing MS are chronically on some of these higher efficacy therapies. And I would say that probably the greatest unmet need that we currently have in practice is developing treatments that can actually halt PIRA and disability progression, because this was the only way that we will be able to address all of the different reasons underlying disability progression in MS. I will hand over to Dr. Fox, who will tell us about some emerging therapies that may have the potential to address this great unmet need. Thank you very much for your attention.
And thank you, Jiwan, for setting the stage for how we treat MS. And thank you all for joining us here early in the morning before what promises to be a very exciting Congress. There are different ways of dividing our current therapies into different categories. This is just one very simplistic view of high efficacy and kind of everything else. I'm not going to go through these therapies. Most of you already know about them, their efficacy. And if you don't, well, this just isn't the right session for you. There hopefully will be some other sessions or maybe at a different meeting to learn about the basics of our disease-modifying therapies. What I would like to do is go through some of the emerging classes of therapies, those that are currently in development, are in clinical trials, and review what we have learned about them. And some we will learn even more this coming at this meeting, particularly at the late breaking news on Saturday morning. So let me start with BTK inhibitors. There's a number of them that are in trials. Some have reported out, some are still in process. In short, BTK inhibitors are thought to work in two main ways: modulation of B cell function without killing the B cells, so decreasing their maturation, their activation, their response to stimuli, but also microglial activation, so changing this arm of the immune system that is throughout the body, but microglia particularly are in the central nervous system. So for BTK inhibitors that can cross the blood-brain barrier at biologically relevant concentrations, it's thought that it downregulates microglial activity, and the various downstream inflammatory responses that come out of microglia. Yeah, so there are 4 different molecules that are in phase 3 trials and some additional BTK inhibitors that are in phase 2 trials. There are different stages, some completed, some ongoing, and some even in the planning stage as well. Let me just review a couple of the results for some of them. First, the Gemini trial looking at tolebrutinib in relapsing MS, and that was compared to teriflunomide, where there was no difference in the annualized relapse rate, the primary outcome, in either of the two, Gemini 1 or Gemini 2 trials, between the tolebrutinib-treated patients and the teriflunomide-treated patients. However, there was a difference in the progression of disability, such that there was slow disability progression as measured by the EDSS in the tolebrutinib-treated patient population. Whether one looked at the 3-month confirmed disability worsening or the 6-month confirmed disability worsening, there was slow disability progression. This is the first time we have ever seen a drug slow disability progression in relapsing MS when it did not have an impact on relapses compared to its comparator. Now, remember, this is an active comparator, teriflunomide. So there was no difference in the annualized relapse rate, but there was a slowing of disability, which was curious. There was the secondary progressive MS trial, non-relapsing secondary progressive MS. The primary outcome here was 6-month confirmed disability progression, and we see a 31% reduction or slowing in the disability progression, or a 31% reduction in the risk of disability progression that was sustained for 6 months. When we look at the different components of disability as we measure them, 9-hole peg test, 25-foot walk, and flipping EDSS on its head and looking at improvement in disability, what we could see is there was also a slowing in the proportion of patients, or reduction in the risk of worsening on 25-foot walk, and a higher proportion of patients with improvement in EDSS, the confirmed disability improvement. Some safety issues to be aware of with the BTK inhibitors. There, at least in this trial, was an increased rate of COVID-19 infections, but very slight, a very small proportional difference. And liver enzymes. So liver irritation is something we see with many of our BTK inhibitors. We're waiting to see all the trials to see if this is common across all the BTK inhibitors. But there's a small proportion of patients who can have a very high elevation in their liver enzymes. That is always seen in the first 3 months of starting treatment. And that can be a very, very marked elevation. And if it's not recognized and the patient instructed to stop treatment, it can be life-threatening. And so that is the big concern and requires very close attention to monitoring of liver enzymes with some of our molecules. Again, whether this is in all of our molecules, we have to see. Another BTK inhibitor, fenebrutinib, this is results from its phase 2 trial, where one can see that there was a relative reduction of 31% in the mean new GAD lesions over the first 3 months of active treatment. Now, this is lumping together the week 4, 8, and 12. On the right, though, you can see the time course that there's really not much of an impact at 4 weeks, but there does seem to be a marked impact by 8 weeks and persisting at 12 weeks. So this gives us a sense of time of onset of when this BTK inhibitor, fenebrutinib, reduces focal inflammation. We can then look at the long-term extension, because one of the concerns with BTK inhibitors is a return of MRI activity with long-term exposure. And what it appears with fenebrutinib is that we don't see a return of disease activity with the long-term exposure, at least out to 2 years, which is very encouraging. Again, the safety here it looks fairly encouraging. We need to see more details about the safety. But again, there is liver enzyme elevation, and 6% of patients had a grade 3 or higher elevation in their liver enzymes compared to none in the placebo. So this is an area we're going to be looking at carefully with all the BTK inhibitors, with particular attention of whether early monitoring can identify patients who are having this liver reaction and to stop treatment quite quickly. So this is being evaluated in 3 trials, 2 trials in relapsing MS and 1 in primary progressive MS. 2 of those 3 trials are complete. We will be hearing the results of 1 of them later on during this meeting. But the bottom line, at least based on the top line results that have been released, is that there is a reduction in annualized relapse rate compared to teriflunomide. There's a third BTK inhibitor, remibrutinib, and that's being evaluated in 4 different trials as well: relapsing, secondary progressive, and relapsing in patients currently treated with ocrelizumab. And you can see the results expected over the coming year to several years. All right, we have other classes of therapies that are being explored in MS. So one that is a brand new to us is anti-CD40 ligand monoclonal antibody. So CD40 and CD40 ligand is illustrated right here at the intersection of T cells activating B cells. It's also illustrated right here at the intersection of T cells interacting with dendritic cells. So this is a secondary signal that is required for full activation of the T cell to B cell interaction and full activation of the T cell to dendritic cell interaction. And so by blocking that co-stimulatory molecule, there is a whole bunch of downstream cascade events. So decreased activation, proliferation, and immune response to the B cells. Also, the T cells don't get a reinforced signal, and so they have a decreased inflammatory response, as well as the dendritic cells. So this kind of disrupts the whole immune activation pathway in a way that's thought to be beneficial for MS. So these are the results in orange of the phase 2 relapsing trial. And then without any highlight is the open label extension. And what you can see in the placebo group, that there was continued MRI activity. In fact, interesting here, at baseline in this placebo group, there was very little MRI activity that then came up in the open label. I'm sorry, not in the open label, during the placebo-controlled period. This illustrates the variability of these MRI measures. But what you can see, particularly with the high dose 1200 milligrams IV, profound reduction in the MRI disease activity that then was persistent throughout the open label extension. And patients who were transferred to 1800 milligrams also had a nice reduction. And again, the lesson learned from BTK inhibitors, look at your long-term extension carefully to make sure the MRI disease activity stays away. And indeed, we see very little MRI activity over the course of the open label follow-up. This is being evaluated in 2 trials, one in relapsing MS and the other in non-relapsing secondary progressive MS. We expect results over the next 1 to 2 years for this. And this to me is exciting because it's a brand new way of trying to treat MS. Whether there's enough modification of the immune response within the central nervous system by this monoclonal antibody, we'll answer that with Previa, the non-relapsing secondary progressive trial. How about obexelimab? I think I'm saying that right. So this is a CD19 Fc receptor modulator. So CD19, similar to CD20 in expression on B cells, and pretty much just B cells. But what this is doing something to block the activation of the B cells without killing them. So thereby leads to decreased antibody production, proliferation, cytokine secretion, and so on. So a down modulation of B cells without killing the B cells. And so that is being carried forward into trials. And then CAR T therapies. So these are cellular therapies that are trying to modify the immune response. Many of them are killing CD19 or B cells, both in the periphery, and hopefully they get into the central nervous system and will kill the B cells within the central nervous system. And some of these cellular therapies do other things like the TRX319 or TRIX molecule, which not just attacks the CD19, but also as a T regulatory to try to re-equilibrate the autoimmune response across the T cells. So these are very emerging. These are phase 1, very early phase 2 trials, but represent a completely different approach to us modifying the immune response in MS. And as I alluded to, a number of these trials will be reading out this coming over the course of this meeting, particularly Saturday morning at the late breaking news. So the ACTRIMS people is paying me to keep you here for the duration of the meeting to hear these results on Saturday morning. They're actually not paying me at all. So with that, I'm going to hand back over to Jiwon to close us out and then open to questions. Thank you.
Thanks, Bob, for a really nice overview of a lot of data. So lots emerging on the horizon. So it will be an interesting time for sure with respect to therapeutics in the next number of years. Okay, so based on the discussions that we've had earlier, as you'll recall, I talked to you about how PIRA has reared its ugly head and it's rampant throughout all stages of MS. This is an unmet need that we have in clinical practice. And then we also discussed these issues that we have in the longer term management of relapsing MS, where we know that chronic immunosuppression over time does have a small but serious risk of infections and other things. And so in clinical practice, there can be many challenges. And this is what we thought we would try to highlight with a discussion of a number of cases. But as you know, in MS clinical care, we're really fortunate because unlike most other chronic neurological diseases, in many parts of the world, we have nearly 30 different treatments, mainly for relapsing MS, but also treatments for progressive subtypes of MS. But when you're thinking about an individual patient in front of you, treatment selection can be pretty complicated because people with MS are very different. They can be at different life stages, have different comorbidities, have different attitudes towards tolerability and safety, as well as risk. And so because of all of this, selecting an MS therapy is not always an easy task. Bob talked a lot about some of the emerging data from some of the BTK inhibitors. And so when you think about the totality of all disease-modifying treatments in MS, you have a wide range of different treatments that have been on the market for different time periods, all have different risk-benefit ratios, tolerability profiles, modes of administration. And so again, different efficacy, safety data, it can get really complicated. But when you look at even a specific category of disease-modifying treatment that has a similar mechanism, so when we think about some of these BTK inhibitors that overall are grouped into the same family of therapeutics because they generally act in a similar way via a certain mechanism. So in this case, it's BTK inhibition. Bob didn't go into as much detail about this, but we could actually dedicate an entire lecture to talking about the differences in pharmacologic properties of some of these different BTK inhibitors that are being evaluated. And based on what we see from some of these early clinical trials, it's very clear that despite the fact that all of these molecules are grouped into the same family, some of these pharmacologic properties, including differences in CNS penetration, their type of binding, whether it's covalent or non-covalent, whether it's reversible or irreversible, their selectivity, all of these things can result in very clear differences in clinical efficacy and safety. And so it gets even more complicated. I just showed you a slide about how selecting a treatment amongst many, many different treatments with different mechanisms and different profiles is complicated. But as we're getting into this new era of therapeutics, even within the same class of drug, based on different pharmacologic properties, things can look very different from an efficacy and safety standpoint. And so it can get even more complicated. So with that, we'll talk about a case. So I'll tell you about Heather. This is a 35-year-old woman living with MS. She's had a diagnosis of relapsing MS for 8 years. She initially presented with what I would call highly active disease. She had multiple relapses in the years prior to her presentation and a very heavy MRI lesion burden initially. Initially, she was started on a first-line oral disease-modifying treatment, but had breakthrough relapses and MRI activity, and so then escalated to an anti-CD20 agent. And she's been stable from a relapse standpoint as well as from an MRI activity standpoint for the last 4 years since she escalated to an anti-CD20 agent. But when she comes into clinic this year, when I ask her how she's doing, she tells me that she's just noticed over the last 2 years just worsening problems with her vision. She doesn't know if it's because she needed to change her the prescription of her glasses or not, but she's also noticed that her legs feel a bit weaker, and she commutes to work to downtown Toronto. And she finds that when she gets off at the train station, she used to be able to walk very briskly to her office, but it's gotten to the point in the last 2 years, and she didn't mention it to me last year in clinic because she thought she was maybe imagining things, but she now notices really with certainty that she can't actually make it a few city blocks without stopping to rest. In terms of her other past medical history, she has migraines, ADHD. She works full-time as a therapist. She's married and has a toddler at home, and she is interested in the next couple years in having additional children. So when I see her, I review her MRI. It's perfectly stable. There's no new MRI lesions, which is reassuring. But when I examine her neurologically, her EDSS is 4. She is clearly having some difficulties walking, and I see some subtle weakness on her exam as well as other pyramidal findings. She also has a decrease in her visual acuity as well. And I would say technically, because she has no clinical history of relapses, this is evidence of PIRA on her clinical exam because she has had EDSS progression. In terms of her medications, she's been on ocrelizumab as well as methylphenidate and rizatriptan as needed for her migraines. Dr. Fox, what are your thoughts about this?
And this, of course, assumes that a BTK inhibitor is available to you. We are in a fantasy world at the moment, since unless you're in the United Arab Emirates, which does have tolebrutinib, the rest of the world does not, as far as I know. So this is in this imaginary world where all of these are an option. Let's also make this further imaginary, and that insurance will allow you to do whatever you want and will cover, which is even more imaginary than we could imagine. This is a challenging situation, and we have this quite often in that patients who have their focal, peripherally driven disease activity fully controlled by whatever the therapy they're on, in this case, a B-cell depleting therapy, and they have a gradual little by little worsening in their disability, and it is a big challenge. I think personally changing to another anti-inflammatory disease-modifying therapy, I've not found to be very helpful. Although some of my colleagues do say, well, let's change from one B-cell depleting to another, from B-cell depleting to another class of therapy, since this patient was on a B-cell depleting therapy. To me, though, the promise of BTK inhibitors and slowing disability progression is encouraging. It's a very different mechanism of action. And so I would have voted down in the BTK inhibitor column as well.
And as we can see from the poll, I think you're seeing it here, almost the majority of people agree that maybe a BTK inhibitor would be useful in this setting. And I agree with Dr. Fox. I think based on the emerging evidence that we have, as well as the fact that we know that some of these BTK inhibitors do cross the blood-brain barrier at meaningful concentrations to be biologically active in being able to modulate B cells as well as microglia within the central nervous system that we know are responsible for those compartmentalized processes that we talked about. This might make sense in this imaginary world where these therapies would be available. Just like we talked about how the BTK inhibitors, based on pharmacological properties, might be a little bit different, there is some evidence that some of the anti-CD20 agents, because of differences in pharmacologic properties and the mode of administration, may have some subtle differences that we're not aware of. And I think there were some additional questions. I think, okay, actually, if I can, so I think all of these questions, some of them we've actually addressed. But this sequencing piece is an interesting one. If you were to go from an anti-CD20 agent that she's on now to, say, a BTK inhibitor, which the majority of you selected, how would you sequence therapy? And then relevant to that, would people consider combination therapy here, assuming we're in an imaginary world where we're able to get these drugs approved? Bob, can I ask you for your thoughts?
Yeah, at this point, and one of the combinations that have come up is combining BTK inhibitor, which seems to slow disability progression, at least some of them, with a more robustly peripherally acting anti-inflammatory therapy. We don't have any experience with it. So now we do that as clinicians. We do things that we don't have experience doing, but we have to realize that we don't have experience combining a BTK inhibitor with another immune modulating therapy. Based on the safety profile, I think it will probably be favorable, but just realize you're going where we haven't gone and we don't have empiric data to guide us. Another question that came from the audience related to this case is about the potential plans for pregnancy and how would that impact things. Many of us are getting more and more comfortable guiding our patients in trying to get pregnant after a month or two following their last B-cell depleting therapy. And there's a lot of evidence to suggest that that is a safe time for women to get pregnant. But the BTK inhibitors have not been evaluated in pregnancy. And so at least at this point, I would not encourage someone to get pregnant while they're taking a BTK inhibitor. And so for many of these women, I would say, get pregnant now if you're thinking about it, because you're only going to get older. You're only going to get potentially more disabled, particularly this patient who looks like she's heading down the disability scale. And to guide her of, this is probably the best time if socially this is the right time for you.
There are a bunch of questions that have come up, but maybe we'll save that for the dedicated Q&A, Bob, and maybe we can move on so that we make sure we get to the next case.
We shall.
Yeah.
We'll do this case quickly because we do have a lot of questions, which is great. We asked for questions. All right, so this is Thomas, a 60-year-old patient. You got the young woman, I got the old guy. I think that was typecasted. But 60-year-old, I'm getting close to that, presenting for follow-up. He has a 15-year history of relapsing MS, no evidence of relapses in more than 5 years, and now he has worsened difficulty with walking. Medical history, hypertension, some depression. He works as a dean of Jiwon's University, has noticed some difficulty in performance of some of the cognitive tasks. Sometimes the deans, you can't quite tell that very easily. Tries to remain active, but is feeling fatigue. His MRI is stable. His EDSS is 4, increasing from 3 a year ago, but you can even imagine the EDSS may not change. I don't look to EDSS changes to guide because EDSS is such a clunky, inaccurate. I look to the patient of, do you feel like it's harder and harder to walk upstairs and long distances and coordinating your hands and things like that. And current medication is a B-cell depleting therapy. So now what would you do with Thomas? Jiwon, how would you approach this?
Well, I think, this is someone kind of similar to our prior case that very clearly is having evidence of what we would call PIRA, or progression that is independent of any detectable relapsing activity. So in this situation, if we are in this imaginary world, I think probably based on the evidence that we have, it really is BTK inhibitors that do seem to, both theoretically as well as based on clinical trial evidence, have some good evidence of being able to target some of these compartmentalized disease processes that we think are responsible for progressive disease biology. And particularly in somebody like this, who's had disease for quite some time and really clearly is likely to not have a contribution of relapsing disease activity, particularly given his age, probably my first choice would be a BTK inhibitor. What about you?
Yeah, I think a BTK inhibitor would be reasonable at this point. We have other therapies in development, and we're not just focusing on BTK for the sake of BTK, but as we see other therapies that are showing benefit in slowing progression in this aspect of MS, the progression part, progressive, I think that will be attractive. The big thing we struggle with is how to potentially combine, if we would combine. And we do have a question about would we worry about disease activity returning? And in the 35-year-old, with the 60-year-old, we have less of a worry, so that is encouraging. But for the 35-year-old, I would be, as we saw in what Jiwon showed with the .MS trial, younger patients who were stopped on their disease-modifying therapy did have a return of their disease activity. And I would be worried about that and would need to monitor carefully.
Agreed. Okay.
A couple other questions then. We can shift to the question part. From a research perspective, what do we think about CAR T therapies as an option for, the question was Heather, but I'll say Heather or Thomas. So would you consider CAR T therapies for these patients, Jiwon?
So as you said, Bob, I think these CAR T cell therapies are intriguing, but they're in very, very early stages of clinical trials. So I don't think we yet know. But theoretically, some of these engineered cells can actually get into the central nervous system and theoretically target processes that are, confined and compartmentalized. So it is possible that there is an effect on progression that we're currently not able to achieve with our current disease-modifying treatments. So particularly if the progression was very rapid and concerning, this might be something that I would consider actually in both patients, but maybe more likely the younger patient, only because there also are risks with some of these therapies too. And so sometimes when I think about the risk-benefit ratio in general, it tends to be a little bit safer in people who are younger and without as many comorbidities.
Okay. So question, we'll shift to some of the general questions across the span of our presentation here. How do we monitor for PIRA in our practice, and how will that change in the next 5 years? We're using different ways of trying to get at how the patient is truly functioning, but I think they're all still pretty lousy. So maybe because I'm kind of an old dinosaur, I just keep asking the patient, have you been getting worse little by little over time? And how does that manifest? The cognitive stuff, I don't really know what to do with, but the walking, usually I can walk up a flight of stairs and then just keep going. But now I have to stop at the top. And a couple months ago, I had to stop halfway up, and because my legs are getting weak, or coordination, I'm not able to do the knitting or the whatever fine finger coordination thing that I used to do in years past. So I still think talking to the patient, particularly with motor and coordination function. Cognitive, it's a little trickier because it's really hard for patients to judge their own cognitive abilities. We see that in the Alzheimer's patients, of course. So I think it's really talking to the patient and then looking for things to confirm what the patient already knows and is telling you.
I completely agree, Bob. I think, we already talked about unmet needs in clinical practice, but I really think one of the unmet needs that we have is how to better monitor for subtle disability progression. And the current tools that we use are simply not enough. The cases we presented actually very clearly had changes in EDSS, but we all know that in reality, probably when you first have some suggestion of PIRA, it really is based on what patients are telling you. So I also ask questions and actually try to target it towards what I know about patients. So if I know that they love hiking, I'll ask if they've noticed any change in the distance that they can hike. If I know that there's a particular sport, other sport that they're interested in, these are the kinds of questions that I'll ask. And even with workplace functioning, cognition is always complicated because there's, fatigue components and variability and everything. But if I know that they're in kind of a high demand, kind of a high functioning job, I'll ask if there have been some subtle issues at work with completing tasks or excessive amounts of stress preventing the performance that they want. So I know these are all kind of somewhat vague measures, but at the current time, because we don't have better tools, I think it's the best we have to rely on.
All right, let me shift. After how many years of B-cell depletion do you become uncomfortable continuing? You shared some of the data about risks. When do you start saying, I'm worried, we need to think about alternatives?
So it really depends on age, I have to say. In younger people, and we kind of touched on this when talking about sequencing with the two cases that we had, I do worry about disease activity return much more in younger folks. We do know that obviously this is not the case in everybody, but as people get into their later 50s and early 60s, disease activity in relapsing MS is much less than it was in the prior decades. However, the issue is we don't know exactly with the patient in front of us how active their disease will be after discontinuation. And so when do I start getting worried? Also dependent on age. In younger folks, I don't worry so much, but say I start an anti-CD20 agent in someone in their 50s, I actually start worrying after probably 5+ years. And that is around the time when you look at some of the data from these studies, really kind of in the 5 to 10 year mark, that you start to see some of these, rare, because these are quite safe therapies, and the long-term data from the pivotal phase 3 trials as well seem to illustrate this. But there is a rare but serious risk of sometimes pretty serious infections.
There is.
Yep.
Let me shift now. If a BTK were available, could one sequence? The questioner asked about sequencing cladribine followed by BTK, but I would say many of our therapies we could consider sequencing. And I think the answer is yes. I think sequencing will become part of our future. We don't know how to sequence, and we need some good studies to understand that. But particularly the every 6-month infusion B-cell depleting therapies, which probably continue their efficacy for 12 to 18 months after their last infusion, that they give us a nice opportunity to sequence something different, whether it's a BTK inhibitor or a anti-CD40 ligand modulator, any of our new therapies. I think the days of leaving a patient on a B-cell depleting therapy forever and ever, amen, is probably not going to be our future. We're probably going to do it for a period of time and then sequence them to something else, monitoring, of course, for the return of disease activity over time.
There's one question that, Bob, I think I would love to hear your thoughts as the lead investigator of Hercules that looked at non-relapsing SPMS. Current clinical trials for SPMS appear to further characterize into another subgroup, non-relapsing SPMS. But given the recent news from regulators about non-relapsing SPMS, particularly in reviewing tolebrutinib submission, the FDA continues to go back to their characterization of MS as active or non-active SPMS. Do we still continue to look at non-relapsing SPMS, or should SPMS trials only look at non-active SPMS?
Well, I think I can't explain what the FDA decision was related to tolebrutinib, of course. I had no input or involvement in it. But what it does seem that they are catching up to the rest of the field in that disease activity is both relapses and new lesions in MRI. And we have considered that for years, that if the patient has new lesions in MRI, regardless of whether they've had relapses or not, we say that the disease activity is persistent and continuing, and we need to do something about it, probably change their therapy. So I think at some levels, the regulators are catching up with this idea of relapses and new lesions as part of the relapsing pathology, and the gradual little by little progression is the progressive pathology. To what degree they are still following the relapsing remitting MS versus SP versus PP, I can't really comment.
I think it's clear, in this era of recognizing that MS is a disease spectrum, our current categorization and all of these categorizations that we have are far from perfect. And so it's quite frustrating knowing that there is this hang up about a designation that is simply another designation trying to kind of reflect what we're seeing in the clinic. So hopefully this is not a big hindrance to eventually getting some of these drugs on the market.
Well, with that, we are out of time. I'm sorry we're not able to get to all of your questions. Many of them are asking quite nuanced and important questions about how we acclimate to some of the comorbidities, whether they're age or other diseases like diabetes and hypertension. And there is a lot we are going to learn about not just BTK inhibitors, but also all of our new therapies as they come. We thank you very much for joining us. Enjoy the rest of the meeting.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by the University of Cincinnati. This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This independent Satellite Symposium is supported by an educational grant from Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/TPK860.